Dr. Satish Chadha. Effect of diabetic screening in referral to HES and reduction of blindness.
Good afternoon, everyone. I'm Satish Chadha, and I'm the clinical lead for the Northamptonshire Diabetic Eye Screening Program. We have a well-established screening program, which is a part of National Diabetic Eye Screening in UK. The population of Northamptonshire is 733,100, and we have a total number of 40,449 patients which are enrolled in our program, which indicates about 5.52% of the population. We have a manager with 3 staff, fail-safe team, grading 10 members of the grading staff, and we have fixed 9 sites and mobile 3 sites. 72 GP surgeries are associated with the program, and there are 2 hospitals, Kettering General Hospital and Northampton General Hospital, with 6 medical retina consultants attached to the program. Now, we follow a 4-level primary grading, secondary grading, arbitration grading, and ROG or referral outcome grading. At primary grading level, if there is R0, M0, which means that there is no, it is a screen negative, that goes to annual screening. All the screen positive goes to the secondary screening, where again R1, M0 go to the annual screening. If there is a discrepancy or disagreement between primary and secondary grader, that it goes to arbitration grading, and again at that level R1, M0 go for annual screening. Any further R2, R3, M1 unclassified, that goes to ROG or referral outcome grading. And this is ROG or the referral outcome grader who decides whether it has to go to the hospitalized service or it can be followed in the community screening in the form of slit lamp biomicroscopy or digital screening. So central point is the ROG screening. All the patients which have been referred to the hospitalized service, once they got treatment, they are referred back to the ROG grader, which again decides whether it has to go to the annual screening or SLB surveillance, or it has to go to digital surveillance. We looked at referral to the hospitalized service from 2012 to 2017, 5 years retrospective study. Strict national criteria are followed for primary, secondary, arbitration, and referral outcome grading. All referrals to the hospitalized service by referral outcome grader were reviewed on a yearly basis. Cohort performance measure in the screening was evaluated as per national guidelines. Here we see in 2012-13, the size of the program was 33,556, which increased to 40,449 in 16-17. The new registration was 2,786 in 12-13, which increased to 4,114 in 16-17. That means there was an increase from 8.3% to 10.15%. The number of the patients invited was 26,331 in 12-13, which increased to 33,615, which means about 86% were invited in 12-13 as compared to 95% in 16-17. This is a referral to the hospital eye service, quite a detailed slide. The main thing is that it includes all the referral to the hospital, non-diabetic as well as the diabetic. The total number is 1424, which is 6.46%, which was in 12-13, and in 16-17 it came down to 3.66%, about 959 patients. This is breakdown of urgent referral to the hospitalized service with gradings. Again, breakdown to routine referrals to the hospitalized service. and the total referral to the hospital eye service in 12-13 was 807, which was non-diabetic, and 621 were the diabetic, and the total number 1424, which was 6.46% in 12-13, and compared to 16-17, 213 non-diabetic patients and 729 diabetic, which is 3.66%. Looking at reducing new blindness, certificate of visual impairment issued was 11, that was severe sight impairment, and sight impairment 7, total number 18 in 12-13, which was reduced to 16 in 16-17 to 4, and total number 8. So overall results, new diabetic registration ranged from 8.3% to 11.68%. Diabetic patients registered increased from 33,556 in 12-13 to 40,419 in 16-17, and out of 116,000 screening episodes in 5-year period, 4.85% were referred to hospital eye service. 60% of referral were due to diabetic lesions. The referral to the hospital decreased from 6.46% to 3.66% in 16-17. To conclude, referral to the medical retina units were reduced gradually. Overall referral to the medical unit were reduced by 50%. There was gradual reduction of sight impairment and severe sight impairment registration ranging from 18 in 12-13 to 8 in 16-17. Screening is therefore an effective tool for selective and appropriate referral to the hospital eye service for diabetic patients. Screening is also helpful in prevention of blindness in diabetic patients due to early recognition and referral of sight-threatening retinopathy. Thank you very much. Yeah, that was in Northamptonshire, which is south of London. No. Thank you.
Home message is that successful screening programs will reduce the burden of, are likely to reduce the burden of referrals to the hospital and the specialty clinics, and reduce the burden of blinding visual impairment.
Yes, the main thing is when appropriately screened, then the appropriate patients, they are referred to the hospital, and non-appropriate referral, like we noticed that in 12-13, there were 720 referrals which were easily avoided, and the referral rate comes down, but the sight-threatening retinopathy where there is present, the referral rate increases.
Yes, so the over referrals, they decrease.
Yes.
The over and the false referrals.
Yes.
Yes, thank you.
Thank you.